Should we start? طيب السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. I'd like to welcome all the attendees in our monthly webinar in pediatric urology organized by the Saudi Pediatric Urology Group. We would like to introduce ourselves. I'm Khalid Foda, a pediatric urologist in the University Hospital, King Saud University in Riyadh. And my co-moderator is Dr. Ahmed Al-Shammari, Head of Pediatric Urology in King Abdulaziz Medical City in the National Guard. I'd like to sincerely welcome our two panelists for today, whom we are very happy that they are joining us. Professor Ashraf Hafid, who is well-known to us in Riyadh. Professor Ashraf is a professor of pediatric urology in Mansour University. Currently, he is the vice president of Mansour University for postgraduate studies, and with us also our friend Dr. Max Chevillon, who is a consultant pediatric urologist from Manchester. Would like to welcome both of you, and the panel will go throughout the next 90 minutes. Dr. Shammari will start with a very short presentation about the topic. After that, we have 8 points. We hope we can finish all of them for discussion. So there will be no detailed lecture by our experts, but it's going to be a few points that we discuss with them. And these points we will give to each one, and we'll give 5 minutes to to each one. It will be up to the panelist if he wants to present any slides with that one. So, Dr. Shammari, if you want to start.
Thank you, Khalid. We thought I would like to thank our guest speakers and thank Dr. Fahad Al-Yami and Dr. Mustafa for organizing this event. We thought that to cut short the time, I'll just give a small introduction about the extent of the anomaly we're going to talk about. It's mostly affecting a lot of defects in the body, including musculoskeletal and anorectal defects, and the male and female genitalia, as well as some urinary defects. I'm going to go through them quickly just to show you the extent of the anomaly. If we started with the musculoskeletal, basically the anomaly is in the pelvis. Actually, when you see a bladder extrophy, it's not only the pop-out bladder plate and the classical epispadias. Most of the defects, or major part of the defects, is in the pelvic bone structures, where there is a complete opening of the pelvis, rotation of two major bones. The innominate bones, they are rotating externally or outwards, as well as the pubic bones more than this. And you could see it in the X-ray. There is a widening of the symphysis pubis. And as a result of this, there will be usually an external rotation of the lower limb. The muscle attachment for the rectus abdominis, it's usually in the pubic tubercle, and it's not affected. The next slide. Usually, the anus is anteriorly displaced, and the perineum is usually broad, and the pelvic anatomy and the pelvic floor muscle is distorted, and it is diverted with the opening of the pelvic bones. So as a result, you will lose the function of the levator ani and the puborectalis. The next slides. With the male, usually the penis is short and it's wide. It's a normal width of the penis, and there is a severe dorsal chordee. The neurovascular bundle are usually displaced laterally. So when reconstructing the problem, you have to take care of this. There is normal vas and normal ejaculatory ducts. Prostate volume is normal, but it, as a result of the epispadias, it does not circumferentially cover the urethra. The next slide will show the female. Female usually vagina is short and sometimes it's duplicated, and it's usually anteriorly displaced, and it's just like behind the bladder blade. The clitoris and the mons pubis are splitted, and as we mentioned, the pelvic floor is also abnormal. Internal organs are usually normal. The next slide. For the urinary defect, upper tract is usually normal. Bladder plate varies the size between 15 to 30 cc bladder. Always there is a histological changes in the bladder mucosa with ectopic bowel mucosa, some metaplasia, some changes with the cystitis cystica, and with evidence of chronic inflammation. Slide. So usually the ureters are inserting into the bladder plate deep in the pelvis. They go inferiorly and then upwards into the bladder plate. And neurovascular supply is usually normal. This is just to show you the extent of the defect. It's not only a bladder which is not closed. So Dr. Foda will take over and will try to cover those points that we mentioned in our talk. Please, if you have any questions, any comments, write it down in the question and answer, and then we'll try to answer them.
Thank you very much, Ahmed. So as I just mentioned, that we'll go over these points one after the other. We'll start with the first question, which is the timing of the repair, early versus delayed, and the factors that help in this decision. May I start with Dr. Professor Ashraf Hafid, then for 5 minutes, then 5 minutes for Max. Thank you. Ashraf.
Good evening, all my friends in the Saudi Pediatric Urology group, and good evening to Max. It's my pleasure to be here with all of you, friends and colleagues for many years. I have the feeling that I'm still in Riyadh till now. So it's my pleasure, and thanks for Professor Khalid Fouda, Dr. Ahmed Shammari, and Dr. Mustafa Al-Gambar, and Dr. Fahd Al-Yami, and everybody in the Saudi Pediatric Urology group. It's a very difficult question. First, what's the definition of early versus delayed? Is it early within the first 3 days of life, or early in the first month of life? Anyway, so my definition is early is in the first 3 days of life, versus delayed, which is around the age of 2-3 months. That's the universally accepted, probably, definition. In the beginning, we used to do all bladder extrophy patients, if they present in the first 3 days of life, to do them right away as an emergency. And things have changed since 2011, 2012, with complete primary repair and cases of penile loss injury because of dissection of the penis in a very young age in the first few days of life. So this study by Anne in 2017 showed that before 2012, 75% of pediatric urologists were closing atrophies in the 3 days of life. Nowadays, the majority, 71% of pediatric urologists in the United States, are closing bladder extrophies in a delayed fashion around the age of 2 to 3 months. Personally, nowadays, we do it delayed around the age of 3 months because of risk of anesthesia in the very young newborn, the renal immaturity, the need to initiate breastfeeding, parental bonding between the mother and the child. And there is no evidence of histological impact of waiting 3 months on the bladder. This is controversial, but there is no evidence that leaving the bladder for 3 months makes a difference. And also, there are many studies that also show that waiting for 3 months does not impact later bladder growth. Lastly, if your plan is to do complete primary repair, I think most people would agree it's not a wise thing to go and do complete primary repair in the first 3 days of life. The downside, for sure, that you will need osteotomies in the vast majority of patients if you wait, but overall, we are satisfied now with the approach of delayed repair at around the age of 3 months. Okay, I'm done.
Max?
Yes. So,
okay.
Well, I don't think there's going to be much of a debate because I completely agree with Ashraf. So we really are keen in delaying the closure because the closure done later on, and actually we have pushed this concept a little bit further because now we close the patients towards the 6th month of life. If I can just go back one step backwards, looking at a wider picture in pediatric surgery, I just think about one of my master, Adrian Bianchi. So Mr. Bianchi was a pioneer for pediatric surgery for many conditions. And what he started asking himself many years ago was, when he was still working in Manchester, do we have to treat some patients very early, for example, in the first 24 hours, thinking about congenital malformations? And he actually realized that he didn't have to do that, even in severe conditions. And actually the outcome, because the operations were not done in the evening or the nighttime, because the conditions were not treated when the patient was unstable, actually these patients were doing a little bit better. So we started with that. We made a step forward around 2004, 2005, when we had the 2 dehiscences for patients who had a very small bladder template. And if I can share with you some thoughts about the size of the bladder. We know that all the extrophies are not the same. And in 2012, we started actually looking at a little bit a mathematical model which could define what's the size of the bladder compared to the size of the patient. And this is what we published on Journal of Pediatric Surgery. And we called it bladder extrophy ratio. And we actually found that patients can have a huge variation in the bladder size, as we know. So we need to consider that. The 2 dehiscences that we had yearly in 2003, 2004, together with one of my former colleagues, Alan Dixon, were due to very small bladders. So we started looking at the bladders a little bit more carefully. And we realized that the bladders can be very smooth, with some polyps, with many polyps. And of course, there is an issue with the urethral plate. The urethral plate can be short, the urethral plate can be long. And all of that made a huge difference. Now, if a baby is born and whoever is on call goes and closes the baby because you have to rush in to avoid the osteotomy, all these elements are not actually fixed. And then it's when the mistakes happen. Now, what we tend to say in Manchester is, if you're lucky enough that you have a baby born with a bladder like that, and you really want to go for an neonatal closure, probably nobody can criticize you. But if you have a baby born like that, it would be criminal to go and close a bladder. So we have now the routine of delaying all the bladders, if they are big or if they are small. And the advantage of that is that the baby is stronger. We have a team dedicated to treat the patient with the usual anesthetist, with the orthopedic surgeon that is involved, and he has done more cases than anybody else is in Europe. So we have a good osteotomy, and we share the experience internally so we can provide what we wanted to provide. So I could go a little bit further, but please tell me if we want to move on.
Your phone, Khalid.
So
I have a couple of questions with you, Max. If you are going to do a delayed one,
Yep.
is it going to be? We basically mentioned about the osteotomy. The complications of osteotomy versus at a patient between the age of 3 months to 6 months compared to the complications of doing an early repair in the first 3 days. What do you think, Max and Ashraf, about that?
well, when we discuss if to do osteotomy or no, we consider some essential points. One is that even in the neonatal period, some patients require osteotomy. So you have to be really, really selective to do a closure without osteotomy. The second thing is, if we want to do osteotomy anyway for everyone to be safe, if we wait 3 months, the periosteum gets stronger, and we can actually start inserting the pins in a little bit more strong fashion, so with an external fixator, and the osteotomy will be a little bit more effective. So for us, delaying the extrophy means delaying at least 3 months. What we found is that at 6 months, the bone is even stronger. And then for the orthopedic surgeon, doing the dissection is actually easier. In our hands, and I'll show you some data later, if you're interested, on an audit that we did over 71 extrophy repair done with the same approach by the same orthopedic team with anterior or anterior combined posterior osteotomy, we didn't have any neuropathies.
Great.
The only thing that we had to do, we had to transfuse them, because with the osteotomy, you lose some blood.
Okay. Ashraf, another question for you. One of the questions came that they are doing bladder, doing the repair without osteotomy, but doing a rectus sheath flap. What do you think about that?
I know, Khalid. I don't have experience with that. Do I think osteotomies or approximation in the pubic bones in the midline makes a difference? I don't have a very good answer or a scientific answer for that. The problem with the bladder extrophy topic, it's mainly based on experience in different centers. We don't have good data, good prospective data comparing different approaches. So we are doing complete primary repair because mainly we are more familiar with the complete primary repair. Is it better than the modern staged repair? Nobody has an answer. And for using rectus fascia without approximation of the pubic bones in the midline, you might close the defect. Would it impact continence later on? I don't know. It might, but I think osteotomies, this is my personal feeling, or approximation of the pubic bones in the midline, makes the bladder neck deep inside the pelvis, and theoretically it will improve the continence outcome. And when it comes to the first question, when delayed versus early repair, I think the only difference is when the group from Seattle looked at it. So the only difference was that higher incidence of blood transfusion for delayed repair and longer operative time. And this is because you will need an osteotomy in the vast majority of patients.
Okay,
I'm done.
Great. So I'll go to the next point, Ahmed.
Next point is, I'm going to start with Max regarding the type of repair. Since you are doing them at the age of 6 months or delayed, really delayed age, do you do them as a single stage repair, a complete repair, or do you do them as a staged? And if you can just share with us how would you decide on what basis you decide that this is going to go staged or this is going to be a complete? Is it the bladder blade size? Is it the bladder blade smoothness, or is it the size? Please.
Thank you. Of course, as Ashraf mentioned, is based on experience. Our experience is that the stage is what it works. Now, we had to think about this very, very carefully. And we had a significant experience around 2005 to 2006 with the complete repair. And we didn't find that in our hands, the complete repair give any advantages. So when we do the stage repair, we think about what we learn, and unfortunately, this is there in the literature about the complete repair. So with the complete repair, the dissection of the penis is a very, very complex dissection. Mansoura is the center which has published the best result with the complete repair. And I think one of the elements which has taught everyone around the world how to avoid the partial disassembly rather than the complete disassembly. And I really learned from Professor Hafez and his team. So the assembly probably avoids the penile ischemic injury, but the complete repair done as initially described by the Seattle group is extremely dangerous. And unfortunately, we face one of these complications in our patient as well. And in this publication, I put together a very large series, which actually was pretty dramatic. That's the first reason we do the stage repair and not the complete repair. But the other one is that when we do the epispadias repair 6 months down the line, it's just a phalloplasty, because with the initial repair, we tubularize the proximal urethra up to the base of the glands. So the urethroplasty is done, and the bladder and the proximal urethra are pushed deeply into the pelvis. So the pelvic floor will work as an external sphincter. The only thing we don't do is to dissect the penis. So we can do simply a genitoplasty later on. And the outcome of the reconstruction in our hands seems to be positive. So we are happy that we don't have a lot of complications. This is my personal experience with epispadias in the last 10 years. And with the stage approach, I have an easy life in a sense that I have only 2.5 hours penile reconstruction rather than to do a very fine dissection after I have repaired an extrophy. And even when I do the delayed extrophy repair stage, there is a lot of swelling which involves the penile area. The prepuce usually is very swollen for 2-3 days, even longer. So I'm glad I don't do the penile dissection, because even if it works in very experienced hands, I don't want to take that chance. And the vast majority of our colleagues around the world, they don't have a lot of experience. So therefore, if I have to teach a way to be safe, I say do stage, and 6 months after, do the stage repair. And so do the epispadias repair, but tubularize the urethra in a way that the bladder can cycle.
Ashraf?
Again, we don't have comparative studies. In our hands, complete repairs do well. We were lucky that we didn't have penile glands loss during neonatal complete primary repairs. So we do complete primary repairs. We shifted to the age of 3 months to keep it safe. And as Max said, there is no rush to do it as an emergency. So why do we do complete repairs or complete primary repairs? It's not actually a complete repair, because when we started with Michael Mitchell visiting us in Mansoura in 1998, and he did the first complete repair in Egypt. And then I carried on and I did 7 cases of complete repair in 3 months. So in the beginning, we thought that it's actually a complete repair, one procedure that will fix everything, which is not true. So I wouldn't say it's a complete repair. I would say it's a different way of a staged repair. The only difference is that you do the epispadias with the bladder extrophy closure. In our hands, the incidence of dehiscence, because we did both, the incidence of dehiscence, interestingly, is less in complete repairs, probably because we position the bladders much deeper inside the pelvis with the complete repair. That's the only point. We think it can be done. It can help in increasing bladder capacity during growth and allow for bladder cycling. Would it affect continence later on? There is no good data on that, but it's emerging, the concept of later development of continence over the years after complete repair. So probably positioning of the bladder deep in the pelvis and the epispadias repair and the bladder cycling would allow for increased bladder capacity, improved bladder compliance, and later effect on continence. Is there solid data on that? There is no, for sure. But in our experience, complete repair are accompanied with better outcome when it comes to dehiscence. And we have a feeling from our data that continence in the long term might be better.
I agree. I mean, I found it, much easier to place the bladder deep in the pelvis when you do the complete repair. In addition, I think it's much easier to do the epispadias with the complete repair in the same session rather than to come on a second stage and go through the scarring of the previous procedure to do the epispadias repair. But it's still, I mean, I tend to do them if I can as a complete repair at once because of the easiness to push down the bladder deep in the pelvis better than the staged repair. Khalid, you want to go to the next? Max, do you want to comment?
The only you both of you clearly states, and then I'm of the same opinion that it's extremely important to place the bladder, what we call the vesico-urethral unit, deeply into the pelvis. It's fundamental. It's the way you achieve that. One way is to do the disassembly, and you place everything down and you create a perineal hypospadias. One is just to tubularize that urethra, because if the urethra is not very short, and only a small part of patients have a very short urethra, you can just put everything deeply into the pelvis without need of doing the disassembly. There is only a small group with a very short urethra, 1.5 centimeter between the verumontanum and the base of the glands, where you struggle with that. And then you need to find a solution. And certainly in those patients, disassembly is an option. I don't like that option, but it's an option.
We are doing very good in time, so we have two questions. We'll give them both to each speaker. The two will start with Ashraf. With the penile size, make you decide we're doing early, late stage rather one stage. And the other one is, what is your best traction method post extrophy repair? Both questions for Ashraf and Max.
Okay, so first question, penile size doesn't affect my decision for timing, because nowadays we do them all at the age of 3 months, and at that time usually they have a good penile size for surgery. In my experience, in our first 50 cases, we were doing them in the neonatal period, and it didn't seem to affect the outcome. However, I would say that around the age, if you are doing everybody at a delayed age, at the age of 3 months, I don't think that penile size would make a lot of difference in the outcome. When it comes to immobilization, I can come to that. We will come to that later in methods to prevent dehiscence.
And I would say the same, so we can discuss about traction later, because it's important to prevent dehiscence. Yeah, if you agree. But for the penile size, I completely agree with what you said, Ashraf, because in fairness, I'm more concerned about the length of the urethral plate that you can consider as a penile size, but it's not related to the size of the corpora or the size of the glands, but really the urethral length, which is so variable. You don't have this issue in epispadias, because in epispadias, the urethral length is always decent. Of course, not as long as normal, because the tissue has not really elongated, so is shorter and wider, the urethral plate. This is the reason we have a very easy urethroplasty to make compared to hypospadias. But the length sometimes is so small that whatever you do, even if you do a total disassembly, that will become a perineal hypospadias. And if it's not very long and you don't do anything, the penis will completely disappear because will be retracted into the pelvis. And the second stage, if you do a stage approach, it will be very difficult, and the final outcome will be very, very, very unsuccessful. So the urethral length is something which is not recognized, it's not written in the books. People don't speak about the urethral length, but actually makes such an important difference.
Great. Okay, so we'll go for the next part for our colleagues, how to overcome the dehiscence. I think this is the nightmare for anyone doing with bladder extrophy. You can see it after a few weeks. We reported a case about 25 years ago of dehiscence after 1 year. This is and so you always have this nightmare. So we start with you, Max. What would you do and give us some tricks to overcome this problem?
Now, we feel lucky because over the years, we have been put in a position where we have achieved a way to avoid the dehiscence. And we really feel that works very well in our hands. So I'm very keen in sharing these thoughts with you because we feel passionate about it. What we tend to say is that over the last 20 years, since we started this project of bladder extrophy repair in Manchester, 1999 is when Mr. Goff started. So we have been able to achieve, over the last 10 years, 100% success in the closure of classic bladder extrophy and bladder extrophy variants. Now, it's a multidisciplinary team approach. And I think if you allow me only one slide, that's the only thing I would say. A multidisciplinary team approach. It's not me, it's not the anesthetist, it's not the orthopedic surgeon, but it's the union between us, which basically allowed the closure. We delayed it, and we delayed it 4 to 6 months. And then now with the COVID, we are delaying even 7, 8 months. Nothing changes, basically. We go and we do a ureteric reimplantation at the meantime, because we feel that that's really beneficial. That doesn't really avoid the dehiscence, but prevents upper tract dilatation and upper tract scanning, which is a failure, considering that these patients are born with normal bladders. Now, in terms of this section, our thoughts are, we all know that it's an anterior defect of the anterior abdominal wall, and the pubic bones are attached to the anterior abdominal wall. So when we start this section on the top of the bladder, we go laterally. We don't even follow the bladder, but we go and we look straight to the margin of the rectus, and we follow the rectus. It's so easy to go down into the plane, just following the rectus, forgetting about the bladder immediately. And then we reach the pubic bones. Then you cannot make a mistake. You find what they used to call intersymphyseal ligament. We'll realize that these are not ligaments. These simply are muscular fiber, which are nothing else than the anterior detrusor, which is fused to the pubic bones. So we have to divide those fibers, otherwise we cannot place the vesico-urethral unit deeply into the pelvis. After we divide them, that's the vesico-urethral unit that we achieve. So all is dissected up to the base of the glands, let's say, and all that unit is going to be placed deeply into the pelvis. And then because the osteotomy, which is the most fundamental part of the procedure, is done by somebody who has got experience, I leave the operating table, Mr. Ali comes and does a combined posterior and anterior L-shaped osteotomy, with insertion of 2 pins on each side, and then it leaves. When I go back, I have simply to put everything in and put 2 stitches of absorbable, so I use Vicryl, into the pubic bones, and I reduce everything to the midline, and everything should stay in. Post-operative management is important. So we have an epidural, so we don't give opioids. And with epidural, basically the patient is basically fed when he comes out of the recovery, as long as everything has been well. And we secure the bladder drainage with a suprapubic catheter. I use a 10 French Malecot and 2 ureteric stents, feeding tubes, 6 French, which drain everything out for 4 weeks. 4 weeks after, I take the child back to theater and I make sure that there is outlet without narrowing. And particularly in the girls, there is always some narrowing there that you can easily stretch with a urethral dilator up to 8 French. And in the girls, usually I leave a urethral catheter for other 2 weeks in a way that everything settles down nicely. And when we think about the traction, we don't do traction, but we keep the external fixator for 3-4 weeks, and we don't tighten that external fixator. If you tighten it too much, you compress on the pudendal vessel. The external fixator is just to keep your pelvis stable, but we don't need oppressing it too much. And the lower limbs are just put together with a mermoid bandage, not tight, just to avoid abduction, because the abduction puts stress on the pubis symphysis. And doing that, these official audit that we did in our hospital, just including the classic extrophy, because during this period, if we put together also those who are variants, we have more than 100 patients. But with the classic one, with the main age of closure, can you see now 5 months with interquartile range between 3 and 7 months, and a minimum follow-up of 4 years, what no other patient develops suprapubic fistula or bladder prolapse. I must say, thank God. And 1 patient required skin and subcutaneous wound debridement, but just a superficial wound infection. And non-neurological complications happen. So we have found in our hands that this way to work allows so far good outcome.
Okay. Ashraf?
So I think prevention of dehiscence starts from selection of the procedure. And in our hands, it's anecdotal, but in our hands, complete repair are better than staged repair or just bladder closure when it comes to that. Anyway, so we over the last 20 years, we have learned the lessons that there are factors in the surgery itself and factors in post-operative care. And as Max stated, the team approach is the key for everything. The orthopedic surgeon, the anesthetist, the nursing, all the team members makes a difference. So osteotomies makes a difference, the way of dissection, and whether we do bladder neck repair, epispadias repair, we will go into the details, and the post-operative factors. And we do anterior diagonal iliac osteotomies through separate incisions, and with the good orthopedic surgeon, you can approximate the pubic bones in most of the patients. So, and as Max said, it's interestingly, in the beginning, what I was taught from Michael Mitchell and the others, we follow the bladder. And in 2001, while I was making a video of bladder extrophy, I discovered that, as Max said, that the best way is to follow the rectus show. So we start with incision of the anterior rectus sheath, and then we follow the medial border of the rectus down to the intersymphysial bands. That's the way. Otherwise, you will lose the way and you will not reach the intersymphysial bands accurately. So we start with the good dissection of the intersymphysial bands. We do the complete disassembly. And with complete disassembly, you can position and the incision of the intersymphysial bands, you can position the bladder deep in the pelvis, and you can approximate the rectus in the middle with the whole thing inside. And we think that complete repair makes a difference in positioning the bladder neck deep inside the pelvis, from the fact that the majority of patients end up with a hypospadias. So this means something. We don't do ureteric reimplant. We don't do bladder neck repairs. We just make sure that the vero is inside the urethra. We do the epispadias by complete penile disassembly. We always repair the hernia. And for pubic bone approximation in neonates, we use #1 PDS suture. It makes it's good, and it can hold the pubic symphysis together. And in older children, we use stainless steel wire and feel it's better. And we always leave 2 ureteric stent and SP tube. And for the ureteric stents, we try 2 approaches. The first approach is Seattle Michael Mitchell approach, when you bring the catheters through the urethra. The other is the Johns Hopkins English way of bringing them through the abdomen. Does it make a difference? I don't know. It was always thought that bringing catheters from the urethra will affect the repair of the epispadias repair. Interestingly, I have learned over the years that bringing the catheters through the urethra will make a vent for buildup of pressure inside the bladder when the ureteric stents are blocked or anyway, so the urine will leak between these stents. That's a theory, but anyway, we did it both ways, and you can bring them through the abdomen or whatever. I don't think that it makes a huge difference. For immobilization, in the beginning, we were using spica cast for everybody, even for the patients who are at the age of 4 and 5. So nowadays, we use the spica cast for younger children, mainly neonates and very young infants. And in the ambulant children, we use external fixator for everybody. Epidural catheter for 5 to 7 days makes a huge difference in immobilization. I think it makes a huge difference, and I would encourage everybody to use that. We leave the stents for 2 weeks, and the SP tube usually for 3 weeks. And nowadays, we keep the patients in hospital for 5 to 7 days. At day 7, I would say 99% of patients would be home at day 7. And early hospital discharge, I think it's better for the family and to prevent hospital-acquired infection and so on. So this is our experience in preventing dehiscence overall. Thank you.
Okay, Ahmed, want to continue?
Yeah, we'll move on to the next point, which is, I think, it's everybody concern, is the our satisfaction about the continence in the long term on those patients. How much you are satisfied with the type of repair that you are doing for Ashraf the complete and for Max for the staged? What do you think? What is your thought and what's your experience about the continence for the long term? Ashraf?
Okay. So honestly, I don't think that we are not doing a good job when it comes to bladder extrophy management. And I think that all of us know little. I will divide our data or continence outcome into girls. So in girls, these patients have more than 5-year follow-up. So these are 25 girls, and after complete primary repair only 5 are continent and voiding volitionally through the urethra. The rest will require a sort of procedure, either bladder neck repair only or bladder neck repair with augment and so on. Interestingly, if you look at 44% of patients who are continent and voiding through the urethra, either following the complete repair only or repair with bladder neck repair, over the years, especially after the age of puberty, we are seeing evidence of progressive hydronephrosis with, we can call it overcontinence, hypercontinence, obstruction, or whatever. You can call it whatever you want. But at the end of the day, they show evidence of progressive hydronephrosis and high residual urines over the years. And we learned this lesson because we are seeing patients who have disappeared for some years, and they show up with renal impairment. So follow-up is very important, and in girls who are continent and voiding through the urethra, you should be very careful because good sector of them will require CIC later on because of overcontinence or retention or whatever you call it. When we look at boys, we have a larger number. We have 70 boys. And out of 70 boys, after complete repair, only 5 are continent for 3 hours or more and voiding through the urethra. And 7 are continent following complete bladder after bladder neck repair. So at the end of the day, 17% of patients are voiding through the urethra after either complete repair only or associated with bladder neck repair later on. Interestingly also, following longer follow-up, evidence of progressive hydro and hypercontinence and retention and so on is shown in significant number of these. And at the end of the day, you will find that 90% of the patients would require CIC at the end of the day. So are we satisfied with our data when it comes to continence? I would say clearly no. And in my experience with other centers, the definition of continence is lacking. So you might argue that it's one diaper, he's not wetting that much, he's dry by day. So, and if you go to a definition of absolute dryness with voiding through the urethra, I would say that the sector of patients who can void through the urethra with no residual urine and no leak is a very small subset group of patients overall. Thank you.
Can I follow, Ashraf? Why do you think this poor results? Is it because we are not approximating the pelvic floor muscle the right way? Or what are we missing in those type of repair?
It's a very good question. I don't have an answer. And I would say that most centers who are doing complete primary repair over the last 2-3 years are showing similar results. I think as the surgeons, we always have a bias towards the procedure that we prefer or do. So I think accurate reporting in the beginning was lacking. And over the years, I have learned that if you don't tighten the bladder neck at time of repair, at time of complete repair, you will end up with incontinence. If you tighten it, probably you will end up with hypercontinence and upper tract deterioration. So nobody has an answer. I don't have an answer. And every year I get the feeling that I know less, and I get less confidence of what I'm doing to these children. And I think the The problem now that the number of bladder extrophy patients is going down. We don't see enough patients, so as we can have good studies to compare different procedures. So you can go either way, tighten it, and you'll end up with hypercontinence, risk of upper tract damage, or do it a little bit on the loose type, and you will end up with bladder neck repair, closure, augment later on. But that's our honest experience over 20 years.
Max, what are your thoughts about the continence after your repair?
I think Ashraf has been really modest because the results he presented are good results, because we are talking about a condition where patients are born with a bladder outside the body. And there are limitations that we have from the beginning of what can be achieved in the long term. And we had, and I completely agree with Ashraf, we had, unfortunately, elements in the literature in the 90s which set the standard so high that nobody has ever been able to reach those levels. And then we had the similar things in early 2000s. And now everybody is starting saying what the results in everybody's hands are like. I would start talking about renal outcomes before we start about continence, because clearly the issue is here, we have the bladder which is attached to the kidneys. And whatever we do to the bladder is going to affect the kidneys. And that's the difference between a pediatric surgeon and a pediatric urologist. Pediatric urologist realizes that and has to do something to prevent deterioration of renal outcomes. And I'm so glad that Professor Asfed has described the renal outcome, because many of our colleagues ignored it. And then it's unacceptable because we are pediatric urologists. This is what we have learned over the last 10 years, because in our 20 years experience, the first 10 years, we had renal scarring in the vast majority of the patients. And we have been perhaps inflicting ourselves pain, asking for the MSA scan to everyone after the age of 5. So we had a lot of renal scarring. What did it change? 10 years ago or more, we started doing the ureteric reimplantation, as described by Professor Pipisale. We started that in 2008, 2009, and we do that routinely to everyone. Also, we introduce a clean intermittent catheterization to the patients after the repair, regardless if they need it or they don't need it. 8 French for the boys and 6 French for the girls when they leave the hospital, twice a day. According to the post-micturition residue, we increase the number of catheterization or we drop it to once a day only. And some of them just stop it afterwards. Doing that at the age of about 6, interquartile range is 5 to 8, you can see that we have 93% of the patients without renal scarring. And when you look at those 3 who have renal scarring, 1 had bladder augmentation only, and 2 had bladder neck closure, bladder augmentation, and continent urinary diversion. Now, none of them had a reduced GFR, but we had before patients with reduced GFR. So this is the reason we are very careful about that. And also, what is important is that clean intermittent catheterization is performed in many of them. In about 32% of them, we do clean intermittent catheterization at the age of 6, because there is post-micturition residue. And we know, pediatric urology, that if you have post-micturition residue, eventually you get cystitis, and then if you have reflux, you get pyelonephritis. So we want to stop the reflux, and we want to stop the post-micturition residue. In terms of the continent procedure that we perform in this group, you see that the vast majority had only the primary repair, because after we close them, and this is what moves Manchester away a little bit from our father center, the John Hopkins, we move away a little bit from the stage that everyone should have a bladder neck repair. We say we do our best to do a repair when the baby is a little bit older, and then we just potty train the patient and we stay away from doing a bladder neck as much as we can, because the bladder neck repair is something which is causing a resistance at the level of you know, the bladder outlet, which is sooner or later will affect the upper tract. So we have to use it very, very carefully. Biofeedback only, some bladder neck repairs, bladder augmentation when we can control the hydronephrosis with just a CIC. And of course, in a group, we do the classic bladder neck closure, bladder augmentation, and continent urinary diversion if nothing else can work for them, rather than to do multiple procedures. Now, these can be achieved. This is a patient who is only 3 years old, and he had a classic extrophy and can urinate. Of course, this patient, if we do a flow study, wouldn't really show a very good curve, but is able to urinate and urinate to completion. And if I show this other one, that's actually a little bit older, and he's able to urinate exactly as we do. And so far, even if he's still young, doesn't have any upper tract dilatation. I don't know if in 10 years' time I'm going to be happy about him, but so far we are happy. But this can be achieved only in a small number of patients. And that temptation of trying to overdo for the vast majority is something that we should avoid.
So you are putting everybody on CIC post-op?
Everyone.
Until the age?
So we start after the repair. So the parents are instructed how to insert the catheter before the child leaves the hospital after the repair. And that's done in the morning and in the evening. They come back for follow-up with an ultrasound scan after 2-3 months, and we look at the residue. If there is a little bit of ureters that you can see behind the bladder and some hydronephrosis, we increase. Otherwise, we keep it twice a day. If later on there is no hydronephrosis and parents say that when they inserted the catheter, there is no really pressure into the bladder, then we just go once a day or even we stop it. But what we learn, as we all know, it's so difficult to start the CIC when they are 4 or 5 years. It's better to start at the beginning, which gives us secure monitoring of the bladder function.
Do you have patients sweating, in between the catheters, or, all the time? They don't have any continent or
Yes.
no control?
I completely agree with you, sir. So some patients do CIC unnecessarily because they leak all the time. But the problem is, if I need to go and do later on a continent procedure, which require catheterization, we have some of them, they really fight so much, they don't want the catheterization. So rather than to create a huge problem, in about 60–70%, we maintain, at least for the first 2–3 years of life, some degree of catheterization, which then can be dropped if we don't need it. And you can see that at the age of 6 years, still 30% do that. Now, if you speak to some of our colleagues around Europe, they think that that's absolutely unacceptable. You shouldn't do that. However, we accept that for spinal bifida. Spinal bifida, they can do. Bladder extrophy, no, you cannot do it. We said, in our hands, I'm sure that there is an alternative, but in our hands, that is helping us maintaining good upper tracts.
A question here, will do CIC per urethra or through Mitrofanov?
Per urethra.
Per urethra. Okay, great. And Ashraf, one of the colleagues is asking, are we achieving continence or dryness?
I'm talking continence on patients who are voiding through the urethra and they are dry. And this is a small sector of patients, which is around 15–17% of the total cohort. And these 15–17% of patients who are continent, really continent, and voiding through the urethra, they carry the risk of hypercontinence, upper tract deterioration in the long term. So they need very careful follow-up.
So the next point, Ashraf, with this mean great experience that you have, I really respect and admire, and still you are not happy with your continence result. What about bladder neck closure with the package of bladder augmentation and the Mitrofanov? Instead of doing a procedure, then you are not going to be happy about it. Now the patient is 10–15 years old, is getting more difficult. Then you go back again to do a bladder closure. What do you think about that? So we'll start with you, Ashraf, then we'll go to Max. Bladder neck closure.
So first we start with bladder neck repair. You go directly with closure.
So I thought we did with that. We're done with that, but we'll go with the repair. Okay.
Yeah, I guess. Yeah.
Okay.
It's a very interesting point here. So the point of improvement of continence outcome or obstruction or so on over the years, we have seen it around the age of 13 years in both boys and girls. And others in Boston Children's and even in the Helsinki group, these are recent data that they have noticed that improved continence in patients at the age of puberty or at the age of 10-year-old. So is it because of prostatic growth, puberty, vascularity in girls? I don't know the answer. So the first question, what is the timing of bladder neck repair? So it's a very difficult question. So if you have a patient at the age of school entry, 6-7-year-old, and is leaking all the time, so would you wait? Would you wait for improvement after puberty, or would you go right away and do bladder neck repair? And depending on bladder capacity, would you need an augment or so on, or would you wait until the puberty? Our practice is that the child at school age should be dry. So we go with bladder neck repair plus or minus augmentation, depending on the bladder capacity at school entry age, which is around the age of 6-7-year-old. In other countries, localities, they might wait till the age of puberty and see the outcome. After puberty, surgical reconstruction of the bladder neck wouldn't be that easy afterwards, after puberty. So it's a very difficult question. Our practice is to fix the incontinence at school entry. Whether it's a right thing to do or should we wait for some time, I'm showing you that there is some evidence in the literature that continence improves over the time, especially after puberty. Would you wait? I don't know the answer for that. It's a very complicated topic, but our practice is to offer the child a diaper-free status when school age comes. For bladder neck closure, we don't do bladder neck closure. We do it only except for failures of bladder neck repairs. If bladder neck repair fails, we go with bladder neck closure later on. Thank you.
What type of bladder neck you do, Ashraf?
We do Mitchell. We do Mitchell bladder neck repair, which is a mixture of trigonal tubularization. So we just tubularize around 1.5 centimeter, 2 centimeter length maximum area and 1 centimeter width area of the trigone. And then we use the anterior bladder wall. We take the mucosa off and we keep this detrusor flap based on the its pedicle, and we wrap it around the bladder neck. So it's a combination of many trigonal tubularization with wrapping of the bladder neck area with the detrusor muscle flap, demucosalized detrusor muscle flap. It works nice with us, and that's the technique we use all the time.
Max, what would be your how are you gonna deal with the continuous sweating, and when do you decide to do a bladder neck and decide to do a bladder closure?
I don't know many slides here, but what I wanted to reiterate is the concept that we feel after we have done the closure, we have put things where they should go. And of course, we have done our best to do it as anatomical as we can, like you do with the complete repair. that's something that if you have some experience with the reconstruction, you try to do your best to make it working. In some of them, and this is the minority, you don't have to do very much. In some of them, you have to do a little bit more. The only difference over the last 10 years has been that we try to stay away from early intervention because that overcontinence that Ashraf described in our hands has been sometimes dramatic. And I tell you, sometimes you really feel, what should I do for this patient? Because he's getting there, but he's not completely dry yet. I saw in clinic yesterday a patient who is now 8 years old, and I've done a primary epispadias, you know, when he was 1 year old, and now he's able to micturate up to 200 mL of urine, and he needs to wear a pad because he's got significant stress incontinence, and he has to change this pad 2-3 times a day. Now, parents are not happy, he's not happy, he's 8 years old, but my alternative here is, or I do a bladder neck repair, and I do a modified Yandiz. I learned from Professor Gerard, and he works well in a sense that you can increase the outlet. It's very interesting, the technique, the Mitchell technique, because I had the privilege of going and visiting in Milwaukee, Professor Mitchell, and I saw him actually doing the bladder neck repair. So looking at the speech, I was remembering what I saw there. The final result, that you do a Yandiz, or you do a Mitchell, or you do a Mollard, or you do whatever you want, or Pipi Sale, eventually you create an outlet resistance, which if you make it tight enough, the urine will stay in. The problem is the urine going to go out without a residue? Yes. If somebody asks me in clinic, yes, can you make this child dry with a bladder neck repair? I say, yes, I do tight. I suspend the bladder neck, it's going to be dry. Well, I don't know if it's going to empty. This is the reason, again, learn from Professor Gerard, we put always a Mitrofanov, because the Mitrofanov can help monitoring again in these patients the post-micturiation residue. Urethral decatheterization after bladder neck repair is difficult. If you do through the Mitrofanov, it's something which, you know, can be easy. But in this patient, you do bladder neck repair, a Mitrofanov, you end with a small capacity, with the hope that the bladder will grow. If the bladder doesn't grow much, you end that you go back in and you do an augmentation. So basically, you have done a stage, you know, reconstruction, which is non-anatomical. So what we tend to do, we stay away from the bladder neck as much as we can. The patient I saw yesterday, I said, Mom, if you like, I'll do it. But I would personally, on my son, wait a little bit longer. And we agreed to wait another 2 years. If he doesn't get more continent, then we have to do something. In terms of bladder neck closure and bladder augmentation, so of course, quality of life for these patients is also important in a sense that you don't want them to undergo, you know, 5-6 major procedures. We don't do injections at the bladder neck. We don't do too many bladder necks just for achieving continence. If the bladder capacity is small and there is no evidence of being able to have dry intervals, I must say that we go straight for bladder neck closure augmentation and Mitrofanov. Of course, I'm not saying that that's something that we do with pleasure, because it's a you know, very radical option, but you know that it secures the continence, and then if you have a family which is complying with the catheterization, it works very well. So rather than to do too much, sometimes if there is no chance of achieving urinary continence, we just go and we do the bladder neck closure.
Great. So now, with what is your happiness or your success for if you are trying to do the bladder neck reconstruction? How's the success rate after one procedure, and how many of them they will need to go back either to make it very tight and using the Mitrofanov? I mean, what is the percentage here?
We are in the process.
Go with Max, then Ashraf.
Of course. We are in the process of reviewing the last 20 years of bladder neck repairs done in Manchester. I don't have the data in my hands. I can just tell you what has been my experience over the last 10 years. And things have changed in terms of achieving urinary continence since I've been put in the mitrophono, because I make a tight bladder neck. I do a tight, long, 3.5 centimeter reconstruction, and I do a suspension, a Marchetti suspension as well. So the child is continent. The thing is, some of them cannot urinate. Some of them can, somebody can't. And then they have to use the mitrophono more than what they are able to pass urethrally. It just has been so dramatic in my experience to do such a major operation with a child that will suffer months and months of training and be still wet. It's really something that really they don't accept well, family and children. So, but of course, in some patients, that's the only thing you can do. You have a go. Now, because of the mitrophono, I make it a little bit tighter. And then in some of them, the capacity develops, the minority, I must say, because the vast majority end with an augmentation afterwards. I'll present the data in the next few years when I put them together. But this is the reason I stay away from the bladder neck as much as I can. That's my experience. Of course, it's something that I wish was a more anatomical. But I remember there was Professor Morikan came to the BAPU a few years ago and gave us a lecture about the neck repairs. And he told us, bladder neck repairs is a fixed resistance that you create there to try to make the child able to keep the urine in and maintaining a passage down below as a security valve. But the vast majority are causing problems.
Ashraf?
Very difficult question. So it depends on you. What's your definition of success? If your definition of success is that you do bladder neck repair in a bladder extrophy patients, and the patient afterwards will be continent, completely dry, and with no deterioration of the upper tract, and with no need for CIC, I would say the success would be 10 to 20%. If you do it with a mitrophono and CIC afterwards, and you do it tight, the success will be much higher. If you do it in conjunction with bladder augmentation and CIC, the success will be extremely high. So the old idea that we learned during our fellowship and afterwards is that you do a bladder neck repair only, and the patient, bladder extrophy patient, will be voiding volitionally through the urethra, dry, with no deterioration of the upper tract. I think this is a dream that it's difficult to reach. And if you take this as a definition of success, success will be around 10 to 20%.
Why I'm asking that, because we are talking to one of the leading in the field. You have your experience combined with the experience of the mentors, whether Gerhardt or Michael Mitchell. Most of us don't have that great experience, but we have to deal with those cases. And if someone with the experience of Ashraf Hafid or Max Manchester, and they are still not happy, I would, me personally, and I tell that to my fellow, I would do just bladder neck closure. I'll be very frank with myself, with my patient, and tell them this is the best to give you the satisfaction with bladder augmentation and mitrophono. Am I wrong?
You are always wrong, Khalid. Max, would you like to start, or should I go on?
I'll follow you, honestly.
It's a very good question, Khalid. So before 1997, our approach to bladder extrophy was to go right away and do rectal diversion or modified types of bladder rectal diversion, like something like the Mainz pouch too, something like that, yeah. And we have around 50 patients who have more than 25 and 30 years follow-up. And when I see these patients in clinic, they are happy. The majority of them are dry. So would you go and do rectal diversion? One question. would you do bladder neck closure and augmentation for everybody? It's a valid way of thinking. But you will not learn the lesson over the years because you take a dramatic decision from the beginning. So you will not understand what's ways of improvement of the outcome over the years. So I wouldn't close the bladder neck for everybody just because I don't have a good solution now. But this might change later on. So I wouldn't break the bridge or burn the bridge for the patient. Things might improve over the years. Maybe we will have something different. And I think patients with bladder extrophy, the main problem is in the bladder. So whatever you do to the outlet or whatever, they have a problem with the bladder. This might improve later on. It might improve. I'm coming with an experience. I'm in the hospital. We augmented everybody passing by the street in front of the hospital. We augmented many patients. We have maybe 300, 400 patients augmented in our hands. So is it the right way to go? I don't know. Augmentation has a lot of inherent complications, and we are seeing them. So patients who have augmentation, they will have problems, some leak through the urethra. Even bladder neck closure is not an easy procedure. They will have problems with catheterization. They will have problems with stones. They will have problems with infections. Data has shown that even patients with bladder augmentation would show deterioration of the upper tract in the long term. And we are starting to see reports of malignancy and augmented bladders. Is it because of augmentation, or it's because of the bladder plate itself that is in context of augmentation, the combination of intestinal and bladder mucosa together? So I think it's a valid approach. Would I go with it? I would rather wait. As I age, you are still young, Khalid, and as I age, I start to be more minimalistic. I don't do that harm from the beginning. I just wait and see. I'm done.
Okay, Max?
I absolutely agree with what Ashraf has said. If I have to do something for a patient who has not achieved that natural continence that we wish after the initial repair, we have to be very, very cautious about selecting him for a continent procedure. This is the reason, after the potty train, after the age of 4, biofeedback is very minimally invasive. We just start them with intense sessions of biofeedback portable machine at home, and we carry on for months and months, and sometimes for years. And then you can see those who improve the capacities, improve the dry intervals, and they come to clinic and they have some distended bladder that they can empty. On those, if they don't achieve good continence and this doesn't carry on improving, then you can consider a bladder neck repair. For the others, if with this wait and see approach, you see that there is nothing there, the bladder is minusculous, and then there is no chance of them reporting any dry intervals, bladder neck closure, bladder augmentation, and Mitrofanov is an option. And of course, it's no ideal option, because we know that in a lifetime, there are so many patients who come back with problem catheterizing the Mitrofanov. Some of them will perforate, and if they don't go to the right place, they will die. So some of them will have a problem with ejaculation because we affected the ejaculatory ducts. So we have to be careful in selecting that option. But I completely agree with Ashraf. And then God knows what in the next few years are going to tell us in terms of understanding more of this condition, that rather than to jump as a cavalier to do a continent procedure when they are young, 4.5 years old, just because the parents have the pressure of taking this nappy away, we just say, well, let's wait. The kidneys are very susceptible to renal scarring in the first few years of life. At least let's come out of the period And then consider option. More you wait, more you understand, then more selective you get in what you do. And then less complication, less number of procedure you need to perform.
Ahmed?
On the same line of talking, what is your thoughts about, after puberty and the prostate growth, that it might help in the continence process? Do you believe in this? Have you seen it in your practice, Ashraf?
Yes, as I said, Abu Naif, yes, we are seeing it. And interestingly, when Michael Mitchell visited us in 1998, he did a bladder neck repair for a 3-year-old child with isolated penopubic epispadias. He showed up 20 years later with renal functional deterioration. So there is evidence of hypercontinence or improvement in continence following puberty, both in boys and in girls. And evidence of new hydronephrosis after puberty, both in boys and in girls. Is it related to prostatic growth? I don't know. Nobody has a good answer for that, but it has been noted over the years that after puberty, that tends to happen, and that's the idea behind the thoughts of waiting and not rushing into bladder neck repairs early in life. I agree that we have seen it over the years. We have seen it in both boys and girls, and others have seen it in both boys and girls. Is it because of the growth of the bladder is more than the growth of the reconstructed outlet, and this way the continence improves over time? This might be affect prostatic growth, vascularity, and so on in girls. I don't know. I don't have a clue for that, but it's an observation that has been noticed by others, and we have the same observation.
But it hasn't been documented and studied either by a radiology study or by a pressure study. I mean, we assume, but it hasn't been proven yet, right?
No, there are evidence. There are evidence of cases that there is progressive improve incontinence after puberty. There is evidence of that. Is it because of prostatic growth, or that the patient is growing while the bladder neck area, because of scarring and so on, doesn't grow well? No, I don't have an answer for that. I don't think that anybody has an answer. Maybe Max has an answer for that. I don't know the cause for that. It's an observation that is documented, but the actual reason for that, I don't have an answer for that.
Max, what do you think? What is your thought about this?
Same observations. The only thing that we have to be clear about it is what hope we transmit to patient and families. If you have a patient who is 8, 9 years old and is continuously incontinent, leaking all the time, comes to clinic, the ultrasound scan shows always that there is an empty bladder, what are we going to say? Let's wait puberty because the prostate is going to grow, and then eventually, we're going to have some outlet resistance there? No, that's not going to work. However, the difference is that patient who comes similar age and he has got a little bit of stress incontinence or significant stress incontinence, it might be that the one is going, the prostatic growth is going to make a difference. Everything is going to make, the body is going to grow, the testosterone is going to stimulate all the muscles, including probably the pelvic floor, and then they start playing football, they become stronger. Some of them will be able to achieve that tiny bit more, obtain a tiny bit more outlet resistance, which is enough for them. But I think those talks that were made a few years ago by some of our colleagues saying, well, let's wait until puberty because our results are going to get better. I think it's a little bit, somebody, to say a joke, we're saying, well, let's wait until they become 70, 80 years old. And then with prostatic hypoplasia, of course, you know, everybody's going to become continent.
Okay, so we did great with time to now. We have 5 minutes to finish, and with the one final question is that regarding the grouping those patients in one or few centers in each country. I think in UK it is very clear. Manchester is one of those centers. How is that? I mean, how we are dealing that from the patient point of view, colleague point of view? Is it still going on, or there is a break of the deal with other centers that they start doing their cases? How rigid in that one? And then we'll take the opinion of Ashraf regarding this point at this our final point of discussion for today. Max?
Very briefly, I'll say that I'm very proud of being part of this project, which started in 1999 and is still going on. And the BAPU, the British Association of the Pediatric Urologists, that I had the honor of serving for the last 6 years as treasurer, has done an extremely good job in maintaining this arrangement. So 1999, they established that the two centers, Great Ormond Street and Manchester, were going to get the Extrophies. And if you see what is meant for us, is that over the years, we have increased the number of patients who have come to us. I wanted just to say one thing about it. When you centralize, you can't just say, I'm an Extrophy center, because they're starting sending you patients, but you are not an expert in the field. You might have a little bit more experience than others, but this doesn't mean that you are an Extrophy center. It takes a long time to develop the experience. And then I must say that Mr. Goff, Mr. Dixon, and all the teams in Manchester, which have alternated until today, have done a progressive work to try to improve our knowledge and our understanding of the condition. And then you need a group of colleagues around the country that understand that why to treat 1 or 2 extrophies per year when you can do a significant number, which allow also to develop the experience of the team. And the team is the one that allows to treat the patients accurately. We have several urology nurses. We have a team coordinator, a colleague of mine who works with me, adult urologist. We have a gynecologist, genetist, of course, great orthopedic surgeon and psychologist. So if you have a centralization which is pushed by the government, you get the funds. This is the reason they allow us to do all that, because the hospital gets paid to do these patients, and then they allow us to just focus on these patients rather than to jump up and down to do other small procedures. So, and that's important. It has worked in the UK. I know that in the Netherlands, there is a similar model, but of course the Netherlands is small. But the UK model has worked, and then I think it's really an achievement that the country and the British Association of the Pediatric Urologists, together with NHS England, have been able to achieve. It's really an important thing.
Ashraf, in 1 minute, I know we are lacking time. Do you think this is, feasible in our setting in the Middle East?
I congratulate Max, and I admire this UK program. I hope it can be applied in the Arab world. In Egypt, I think you can do it in Saudi Arabia. You have the power to do it, Khalid and Abu Naif. In Egypt, it's difficult because we don't have a unified healthcare system, because we have university hospitals, Ministry of Health hospitals, different settings. And pediatric urology is practiced by urologists, pediatric surgeons, so it's difficult to achieve. I hope one day we will have the power to do that. But I think personally, this will make huge difference in the management of bladder extrophy and other rare congenital anomalies in our countries. And I hope you did a good job for spina bifida in Saudi Arabia, and this is a tribute to you and Abu Naif. You did a great job for spina bifida patients. I think you can do the same for bladder extrophy patients, and I can help with that in any way. And I hope one day we can do it, but I think that's the way to go.
I think it's a dream that we hope we'll see it one time. Ahmed, as a closing remark, please. Thank you very much.
Thank you, everybody. It was a lovely discussion, and we enjoyed your experience and your thoughts and your insight in this difficult anomaly that we are facing. And I guess, as Ashraf said, you know, when we are getting older, we really are slowing down and selecting more the procedures and try to be wise in making the decision. Thank you, everybody. Thank you, Max. Thank you, Ashraf. Thank you, Khalid.
Thank you very much, everybody. Ashraf, Max, it was a great evening with you.
Thank you, Khalid. Thank you, Bunay, Mustafa, everybody. Nice meeting you.
Have a great evening. So you can go now and watch the match. I think started.
Okay.
Bye-bye. Thank you.